Hello and welcome back to the channel. You've joined myself, Dr. James Gill, for another clinical skills video. Well, kind of. Today I'm going to try something different. We're going to try and do some MCQs, some multiple choice questions. But how am I going to try and do that as a video? Well, one of the things I don't like about MCQs is they kind of say, yes, you got it right, no you didn't, and you maybe get a little bit of a blurb. But the bigger focus is actually being on writing the question as much as anything. I've done the converse here. I've put more work, I think, into writing about the answers, and I want people to understand why they got something right and also why other answers are wrong. So often it's easy to know the right answer, but sometimes you can see ones that think, well, maybe that would have been right. So I want to be able to try and consolidate both of those. So I put out a request the other day on the Communities tab asking people which particular area we should focus on for this trial, whether we're to do gastroenterology, respiratory or endocrinology. And it appears that most of you wanted to do something from the endocrine system, so we've given that a go. So our first question then. Derek, he's a 55-year-old postman and it's been very hot over the last week. And Derek has felt somewhat dehydrated as a result. Because of this dehydration, he's made a concerted effort to drink more fluid. In fact, he thinks he might have been drinking up to 4 litres a day. Now, he's managed to get that down in the heat, but it's been a really long week. And by Friday, he was finding he got a slight headache and generally just wasn't quite with it. So he drank another pint of water and then went to bed. Despite having gone to bed early, when he woke up in the morning he was still feeling very tired, but his wife was a little bit concerned about him because he seemed a little bit confused. Now when we say confused, he was walking around the house trying to find his car keys, yet he'd got the car keys in his hand. And when his wife asked him to make some tea for her, he put the milk in the kettle. So being very worried that he may be having a stroke, she takes him to the A&E department, and one of the receptionists realises something is very wrong and goes and gets you to see him straight away. When you see Derek, yeah, you agree there's something not right here, but you can't put your finger on it. So you do some blood tests straight away. The first test to come back is his U's and E's, his urea and electrolytes, which is showing a low sodium of 102 millimoles per litre. Derek is severely hyponatremic. So to clarify, our normal levels of sodium will be 134 to 145. We'd say someone is hyponatremic if we're dropping below that 135, and we'd say they were severely hyponatremic if we're dropping below 120 millimoles per litre. So there's your stem, and I suppose it's time for the first question. So Derek probably has induced hyponatremia from drinking too much fluid. However, when we're looking at a severe hyponatremia, we need to keep in mind there are medical conditions that can cause that, which we need to be very conscious of. So, your first question is, which of the following list is not a medical cause of hyponatremia? And on our list we have hypothyroidism, we have Addison's disease, we have SIADH, so syndrome of inappropriate antidiuretic hormone release, we have the use of cocaine, the use of diuretics such as spironolactone or furosemide, we have congestive heart failure and cirrhosis of the liver. So we're going to give you 1 minute to think of the answer and then we'll confirm what's going on. So, how did we do that? I hope you identified the incorrect answer, that being the use of cocaine. Kind of a bit of a sneaky one to start off with, because it's the use of MDMA, aka ecstasy, which is the cause of hyponatremia. Now, as a bit of background for that, there are three major reasons as to why ecstasy can cause hyponatremia. The first is ecstasy-induced thirst, or polydipsia, so people literally wanting to drink loads and loads and loads. Ecstasy will stimulate the release of vasopressin, a hormone causing the kidney to suck up to reabsorb more water. And, as a facet of how ecstasy tends to be used in nightclubs and raves and things, it's in an environment where there is readily available fluids. And one of the side effects of use of ecstasy is hyperexia, or hypothermia, so a temperature. And people who use ecstasy tend to be aware of this and thus try to control that by drinking fluid, which starts the ball rolling towards our possible hyponatremia. But what about our other answers? As I said, I wanted to make sure that we understood the topics and we went over all points of this. So let's look over those in detail. So hypothyroidism can cause hyponatremia, but it's specifically chronic hypothyroidism because you're getting a raised level of ADH, antidiuretic hormone, which, as the name suggests, stops you producing urine. So we've got decreased excretion of water from the kidneys, hence why all patients with hyponatremia need to have their TSH, their thyroid stimulating hormone, checked in order to rule out hypothyroidism as a cause. Addison's means that the adrenal glands aren't able to produce their normal hormones, particularly cortisol and aldosterone. Now, the lack of aldosterone means that more sodium is pushed into the urine because aldosterone is important at regulating sodium reuptake. The other hormone lost due to the adrenal glands not functioning properly is cortisol. So the lack of cortisol means that we've lost the chemical suppression of the antidiuretic hormone, the same hormone that we saw causing a problem with chronic hypothyroidism. So we end up with a double effect. On one side, we've got one hormone pushing more sodium out of the body, and on the other, we've got one pulling more water back into the body, reducing the concentration, and that's the crucial thing, the concentration of sodium in the blood, which obviously is our hyponatremia. The next cause is SIADH, the syndrome of inappropriate antidiuretic hormone release. The clue's kind of in the name here, given that ADH has played a big role in hyponatremia, as we've seen in hypothyroidism and in Addison's disease. When you've got excess or inappropriate production of ADH, it's going to cause problems. Now, the question is, where and why is that occurring? The syndrome of inappropriate ADH release can be caused by many things. It could be an issue with the central nervous system, for example, meningitis resulting in irritation and stimulation of the hypothalamus, or multiple sclerosis or trauma. It may be a cancer, such as a lymphoma or lung cancer, releasing ectopic, an abnormal location release of ADH. Could be lung cancers or perhaps asthma or pneumonia, all of which, along with cystic fibrosis, can cause increased levels of ADH. And similarly, drugs can be an effective cause, such as ecstasy. Can we see things are going in a circle here? But also morphine, carbamazepine can be issues. But to wrap things up from an SIDH perspective, we can also have genetic issues as well. So with diuretics, you're producing more urine, so you're creating a volume depleted state, which the body says, oh sugar, I need more fluid back, so produces or increases the production of antidiuretic hormone, as we've seen with hypothyroidism, SIDH, all of these things. The antidiuretic hormone is a big key factor here. Now, heart failure is an interesting one, particularly in later stage heart failure patients. There we're looking at an impaired kidney function, and that's going to significantly impact on diuresis, so the production of urine. Because we've got a reduction in the ability to produce urine, it means we've got more fluid. So we have more water retention, hence the swelling that we often see in these patients' ankles. That in itself is going to cause hyponatremia. But diuretics, as we've just highlighted, are a problem. are a mainstay of treatment in congestive cardiac failure because we want to try and get that excess fluid off, but that's also then going to cause diuretic-induced thirst and raise levels of ADH, again putting us at risk of hyponatremia. Finally on that list we had cirrhosis of the liver. Here, advanced cirrhosis, you can develop a secondary syndrome called hepatorenal syndrome. So with the impairment of the kidney to secrete water, water is again retained and we get a build-up of fluid. As a result, again, we're running into hyponatremia. So that's question one. How did you do? Hopefully you were able to identify our inappropriate issue there, being cocaine, and learnt a little bit about the other answers as well. So we've established that Derek has acute hyponatremia. Ideally, we need to treat the cause, but that's going to take further investigations, which we're not going to have the ability to do in the A&E department. So our next question has got to be, in the A&E department, what are we going to do to help Derek in the short term? So, which is the correct answer below? Are we going to give Derek salty foods? Are we going to give him IV normal saline? Are we going to give him furosemide, a diuretic? Are we going to give him normal saline and furosemide? Are we going to give him hypertonic saline, so increase levels of salt in the saline? Or are we going to restrict his fluid intake? As ever, you've got 1 minute to answer the question. Good luck. So the answer is hypertonic saline. Now we need to keep three things in mind when we're going to determine the treatment of hyponatremia. First off, the severity of symptoms. So confusion here is pretty high on my list, so I'm happy to say we've got a severe hyponatremia here. The duration, it's likely acute given we know Derek has been drinking excessive amounts of water. And our volume status to determine if he's hypovolemic or euvolemic. Again, given we know that he's been drinking the fluid a lot, then it's likely he'll be euvolemic here. So because we're dealing with a severe hyponatremia, when it comes to replacing the salt, we need to do this slowly so as not to cause problems with the brain. As it stands, given we're talking about acute severe hyponatremia, the confusion is likely due to swelling of the brain due to the low sodium levels in the blood. With regard to replacing the sodium, our aim is to increase the concentration by about 4 to 6 millimoles per litre over the first few hours. Now that sounds a wee bit vague, as there are different guidelines and none of them quite agree. But the one thing everybody is happy about is that we shouldn't be increasing the concentration more than 10 millimoles per litre per day. So we do very much have a top line there. Now, because we're dealing with a severe hyponatremia, the sodium needs to be given slowly due to the fluid shifts in the brain which already have occurred, moving from extracellular to intracellular, because the fluid will follow the sodium, and because there's now more sodium in the cells, that's the way the water is going to go. Thus, there will be swelling already in the brain, and that's probably the cause of the confusion that Derek's wife was so concerned about. Now, our aim is to increase the sodium concentration by about 4 to 6 millimoles per litre over the first few hours. Now, that sounds a bit vague as the different guidelines are conflicting, But the one thing everybody is happy with is that we shouldn't be increasing the sodium concentration by more than 10 millimoles per litre per day. But why? Why? Because it risks damage to the brain. Now, by contrast, when we're talking about a chronic severe hyponatremia, we still need to keep a slow replacement, but here the damage is different. Here there's a risk of osmotic demyelination syndrome because the changes in intracellular and extracellular fluids, because the brain has already adapted to that chronic hyponatremic state. So in reality, we're going to use 3% sodium chloride solution, and we're going to give 150 mils over 20 minutes. But here's the crucial bit. 20 minutes after we've given the saline, we need to recheck the U's and E's, the urea and electrolytes, to see what the new sodium level is in the blood and to make sure we're not pushing too fast. So that's the answer, but what about the other answers? Well, giving him salty food may be something we can look at with somebody who's mildly, chronically hyponatremic, but in this situation, it's not going to help. IV normal saline isn't strong enough and would potentially exacerbate the hyponatremia due to inducing SIADH. Furosemide, although this is a good thought, it's not for acute hyponatremia due to having a very slow effect. IV saline and furosemide is possible as a combination in moderate hyponatremia, but certainly not in severe hyponatremia. Fluid restriction, again, that's a sensible option, like our providing increased salt intake, but would be not appropriate for severe hyponatremia, but because again, it's going to be very, very slow. So we've given you two quite challenging questions there. Let's try and give you an easier one. So I want you to think about what other investigations you could perform either to establish the cause of hyponatremia in Derek or a similar other patient. If you want to make things a little bit harder for yourself, look away from the screen now. Whilst everybody else can see the MCQs, they're going to identify the least correct answer. I want you guys to write down 4 investigations that you could do to look for causes of hyponatremia. So for everybody else not looking away, please identify the least appropriate investigation here to identify causes of hyponatremia. You've got 1 minute. Good luck. So what did you come up with? I would say that blood glucose here is our odd one out. Yes, pancreatitis can cause hyponatremia, but I'd expect that patient to be in significant pain, and I think it's the least appropriate answer. I hope those of you who weren't looking at the screen were able to write down 4 possible answers. So these are the ones that we've got. So thyroid function test, obviously this is self-explanatory as we've already highlighted. Hypothyroidism can cause an issue with hyponatremia. Then we have the synecthin test. This is used for testing Addison's, which we've highlighted is a cause of hyponatremia as well. This is quite an interesting test. So what we do is we check a patient's levels of cortisol at the start. Then we give them an artificial form of ACTH. This will stimulate healthy adrenals to produce cortisol. And we then recheck their cortisol levels after an hour. If the levels have risen sufficiently, we know they don't have Addison's. Conversely, if we haven't seen the expected rise, then we know that they have adrenal insufficiency, and we may have found our cause. So checking urine osmolality would be a reasonable test for hyponatremia, but would also be done along with the plasma osmolarity, because that's allowing us to test for SIDH. If you've a low serum osmolarity due to, for example, water retention, that will allow us to confirm that we had an SIDH by then finding a very high osmolarity in the urine. The problem being is once you've diagnosed the patient as having SIDH, you need to find out what's the cause of that SIDH. Bear in mind again, is it neurological? Are we talking about a lung issue? What is the cause of this inappropriate production? In terms of checking the BNP, well, that's a good test for heart failure, and as we've highlighted, heart failure can lead to hyponatremia. Now, pregnancy is also a potential test for hyponatremia. Now, I'm sure there's a few of you would want to query that, but it's quite common to have a normal volemic hyponatremia due to the increased circulating fluid when there's a baby on board. And I would argue that that is probably more likely than having pancreatitis. So, that's our brief rundown on hyponatremia as a series of MCQs. I hope it's been interesting and useful. Please shout out if you'd like us to try and do this with other systems and other conditions, and we can certainly look at how to improve it. And hopefully when I do the next one of these, I'll be a little bit further away from a pharyngitis than I am now. I'll be honest, when I started filming this, I didn't think there was any problem with my voice, but it's clearly gone quite croaky. So if this has been useful, please like the video, please subscribe to the channel to be able to see when we're doing the next ones, and hopefully that will lead you to engaging and helping us produce better videos on the Communities tab. Take care, we'll see you in the next one. Cheerio.